Hello, everybody. I'm Ijelin. I'm a neonatologist from National Cheng Kung University Hospital. And it's my honor to have this opportunity to introduce you Dr. Wang Zhentian, who is an well-known professor in the field of neonatal critical care. He was graduated from Taipei Medical University in 1966. And then he moved to United States and started to work in NICU at Columbia since 1973. And at that time, the field of neonatology is very pretty primitive. And Dr. Wong is always working at the bedside and solve the problems, the clinical problems himself. We know that Columbia is famous for their remarkable respiratory care. And Dr. Wong is the key person that made this happen. And the most remarkable things there is that he's a pioneer in bubble nasal CPAP therapy. And Dr. Wong has many clinical experience and clinical pearls for neonatal respiratory care, such as gentler and kinder ventilation with preservation of spontaneous breathing and permissive hypercapnia. His publication included 60 peer-reviewed journal articles and book chapters. He is also a recipient of many honors and awards, and I believe that we don't have time to tell you all about that. All about them. And of them, one of them, the most remarkable is that the Pioneer Award section on neonatal and perinatal medicine from the American Academy of Pediatrics, AAP, in 2018. Today, he will give us a mini lecture entitled Airway Care in Neonates, and for our online workshop. So let's give him a warm welcome.
Hello. I'd like to share with you my experience with airway care in neonates. So when we intubate the newborn, you have to, just like adult, you have to make sure head should be in the sleep position, the neck slightly flex, and the head slightly extend. And if the neck overflexion like this, or the head overextension like this, this is almost impossible to intubate baby in this kind of positions. This intubation box, everything we needed in the intubation is in this box. When we do the laryngoscopy, we will, if the patient sleep breathing, we'll give oxygen by tapping a tube on top of the laryngoscope braid and just connect to the oxygen. And so when the baby is breathe spontaneous, still has spontaneous breathing, he will get the oxygen, so he won't get a hypoxic. And this oxyscope, I helped the company design this 1973, so you can connect to the oxygen. And most of the people now, when they do elective intubation, you will give one of this medication as a sedation. And when you see a patient head like that, face like that, you know this will be very difficult intubation, and you should prepare for it. And endotracheal tube, for under 700 grams, we use a 2.5 millimeter ID 700 to 1500 gram uses 3 millimeter ID, and more bigger than 1500 gram, we use 3.5 millimeter ID endotracheal tube. And if the patient will be intubated for a while, we prefer to use a nasotracheal intubation, because nasotracheal intubation compared with the oral tracheal intubation, the nasotracheal intubation had a better fixation and less inadvertent extubation and less tracheal irritation, and more comfortable for the patient and better oral hygiene. And the endotracheal tube length for the oral intubation, usually we use 6 centimeter plus the body weight in kilo. But I noticed some of the neonatology, such in Taiwan, tell me they probably use a 5.5 centimeter. And if for nasal intubation, then we use this table. For instance, you have a 40 centimeter crown here length, and the nasal tracheal intubation length should be 8.75. And after intubation, you should have a chest X-ray and keep the head in neutral position, and you want the endotracheal tube at 1 centimeter above the carina for the baby under 1,000 gram. If 2 kilogram, you can keep an endotracheal tube 2 centimeter above the carina. So you have to pay attention to what the length of intubation, such as this patient, see the tube is into the right main bronchus, so you are not helping the patient. And after intubation, you want to spend some time carefully secure the endotracheal tube. And a newborn or a premature baby, there's no teeth, so you maybe tape well, but you see the tubes, they can pull up and the tube become too high. And if the tube can be pushed in, and this tube will become too low. And some in the United States, a lot of people are using this nail by ET tube holder to hold the oral tracheal intubation like this. And and this nasotracheal intubation tape, we have this tape go along the neck, so it's more secure. And when we do the nasotracheal intubation, we use this forceps, alligator forceps through the mouth and to hold the endotracheal tube and guide into the trachea. And the tube, we don't leave the tube outside too long, otherwise we'll increase the resistance for the baby to breathe and also harder to suction properly. And this patient like this, they maybe become agitated or deteriorated. And what is needed is a suction, but unfortunately, a lot of people, instead of suction the patient, they give it this newborn sedation. So this patient be transferred to Colombia for possible ECMO, and you see before suction, and after the suction, we cannot do the respirator setting fast enough. So this patient doesn't need ECMO. And you see the after suction, they still have a secretion in this tube. So it's important to suction the patient. And suction catheter size, when you suction, you want to use it as big as possible, like 6.5 French or 2.5 endotracheal tube, 8 or 3 or 3.5 endotracheal tube. And you insert the suction catheters through between the connection between connector and the endotracheal tube. So if you go from here, then this lumen are smaller. So you, for instance, you have 3.0 tube, you probably cannot suction with the 8. If you suction from here, you can use 8 French. From here, you cannot. You probably have to use 6.5. And if you have a hard time to insert the suction catheter, maybe because the tube is too dry, you can lubricate the suction catheter with sterile water or saline. And you have to pay attention to the suction length. We like to suction to membronchus, to the membronchus. You know, suction excretion doesn't jump into the tube. With suction, you have to go in to get it. So hold the baby under 1,000 grams with endotracheal tube plus 3 centimeter. If 1,000 to 2,000, you 8 to 4 centimeter beyond the tip of the endotracheal tube. And if more than 3,000, we 8 or 5 centimeter beyond that. And you should take a suction take as short as possible. And the pressure, you need a pressure same as a suction adult patient because the suction catheter is small, the too much resistance. And you suction every 2 to 4 hours or PRN when there's a secretion in the tube. And as I said before, we would like to suction down to the membronchus. So there are 2 membronchus, so you have to suction at least twice. You want to, for instance, you want to suction the right membronchus, you will turn the baby's head to the left, so the chance the suction catheter go to the right side had a better chance to get into the right side. You want to suction the left membronchus, you turn the baby's head to the right side. And we have this car on the right arm, what the suction catheter length. And also like to say something about laryngeal mask airway. This was developed by a British anesthesiologist, Dr. Archie Brand, in 1988. Used this as alternative to the face mask in the operating room during anesthesia. And this LMA also can provide a resolution for difficult airway and used as an airway rescue in a cannot intubate, cannot ventilate situation. And the LMA is good for PAD-1 sequence patient with airway obstruction. So you just you can prevent intubation. And to insert the laryngeal mask airway, some people will deflate the cuff, but some people prefer partial inflate, inflate, and use water-soluble lubricant to lubricate the mask, and the patient is placed in sling position, and a finger is pressed on the anterior surface where the tube joins the mask, and the posterior aspect of the LMA is pushed along the hard palate, following the natural curvature of the oropharynx. The LMA is passed behind the epiglottis or arytenoid and hold the tip to large in the area of upper esophageal sphincter. And this LMA, you just have to tape on the upper lip so the patient can open the mouth, And if they're comfortable, they don't need sedation. And you can use a stethoscope bell to listen to the air exchange. And you can connect to the CPAP setup circuit. And you can ventilate the patients through the LMA as well, as long as the pressure is not setting is not too high. And this patient had a PAD, as you can see, a PAD-1 sequence. So after birth, he had a very severe obstruction, airway obstruction, so had to be intubated, but with a difficulty. So after that, the patient transferred to a tertiary center, and after 4 days old, they tried to extubate. But as soon as they extubate the patient had a severe airway obstruction, has to be intubated right away. But with extremely difficulty, had a complicated with subcutaneous emphysema and pneumothorax, and also require short-term CPR. So they are afraid to extubate the patient. So patient was intubated until 19 days old. So when they extubate again, the patient had a severe airway obstruction. Because if a patient is intubated, they cannot exercise their pharyngeal muscle, so the obstruction don't get better. So instead of to intubate the patient, put on LMA, and that solved the problem with airway obstruction. And this LMA will be changed every day. And when you take it out, you observe the respiratory obstruction, and you will find out every day obstruction getting better and better. This patient, at 4 days later after he on LMA, his respiratory obstruction is resolved. Thank you for your listening.